In this video, we'll be reviewing the metabolic fate of Clopidogrel or Plavix, essentially how it gets from its tablet formulation all the way to its antiplatelet effect in the human body. Now the story starts with a typical 75 milligram dose of Clopidogrel or Plavix. It's only available as an oral formulation, so when it's taken orally it enters the GI tract, and within the GI lumen, eventually the goal is for that drug to cross through an enterocyte within the GI tract, end up being absorbed into the venous circulation, in this case the portal vein, where it makes its way to the liver. Now this is how most drugs are absorbed. However, not uncommonly, some of these drugs will encounter a protein called ABCB1. Now a better term, or more well-known term for this, is P-glycoprotein. And this is an efflux pump, essentially meaning that as that drug goes into that enterocyte, some portion of the drug, as it is being absorbed, will actually be kicked out through that transporter called ABCB1 or P-glycoprotein. So this is really the first step in how Clopidogrel may not make its way all the way to its antiplatelet effect because of the fact that some drug will not be absorbed. It'll be kicked out back into the GI lumen by P-glycoprotein, never able to make its way into that portal vein. So once Clopidogrel is actually absorbed into that portal vein, it actually undergoes several different chemical reactions in the body. The first one that occurs is actually hydrolysis. And this is before the drug even makes it to the liver, and about 85% of that drug molecule that is absorbed in the GI tract will actually be converted to this product called SR26334 that is inactive, has no role, and will be excreted later on. So this really has no value in terms of its antiplatelet effect. What we want to see is the remaining 15% of that Clopidogrel be absorbed, goes to the liver, and at this point the liver is responsible for converting Clopidogrel, which is inactive, into the 2-oxoclopidogrel form, which is also inactive. Now this process is primarily mediated by CYP enzymes. The main one is going to be 2C19, but there are some other isoenzymes involved like 1A2 as well as 2B6. However, the vast majority of this conversion process happens with the CYP enzyme system of 2C19, and we'll talk a lot more about that soon. So once we have this 2-oxoclopidogrel molecule, that also undergoes further hepatic enzymatic conversion, again, primarily through 2C19. However, other enzymes are also involved, like 3A, 2C9, 2B6, and there's actually a number of other ones also involved. But again, just like our previous process, 2C19 is the big major player involved in this conversion process. Now, once Clopidogrel goes to the 2-oxoclopidogrel that then goes to this compound here, R130964. This is the active compound of Clopidogrel. So if you don't make this conversion happen, you will not have enough of this active antiplatelet molecule that will eventually make its way and have an antiplatelet effect. So it should stand to reason then that if there's a problem in this 2C19 enzymatic conversion, you're not going to be able to activate enough Clopidogrel to have the same efficacy that you might see versus a patient that has adequate 2C19 activity. There's actually a lot of good data about genotyping this enzymatic system of CYP2C19, and within that we know that there are specific SNPs that can occur that will effectively make Clopidogrel work better or worse depending on a patient's genotype. So of the genotypes we have STAR1, which is the wild type, which is quote-unquote the normal antiplatelet effect. So this is someone who does not have a loss of function or a gain of function allele within the 2C19 enzyme system. Now we have a lot of data for a loss of function allele of STAR2. So most of our data is actually with STAR2 in terms of a loss of function. The next most common loss of function is STAR3, although that's quite a bit less common. And for both of these alleles, what we'll actually see is a reduced antiplatelet effect. Basically what happens for these patients is that they don't have enough 2C19 enzymatic activity. They have a reduced 2C19 enzyme. It doesn't work as well, therefore it doesn't convert enough of the Clopidogrel to its active antiplatelet molecule, therefore we have a reduced antiplatelet effect. The third variant type that we see is a STAR17 gain of function allele, and these patients that have a STAR17 actually have better antiplatelet effect because they have higher activity of this 2C19 enzyme, so they convert more Clopidogrel to its active compound, and we can see enhanced antiplatelet effect because of this gain of function allele. Now, to put a number to it, in terms of how common these alleles are, for a star 2 allele, this is about 15% incidence in African Americans. It's 30 to 35% incidence rate among Asians. And in Caucasians, we're looking at about 12 to 15%. On the star 3 side, this is actually extremely uncommon in almost all ethnic groups except for Southeast Asia or kind of Northern Australia area. And among those, we can see an incidence rate approaching 15%. Again, all other ethnic groups, this is incredibly uncommon except for those very Southeast Asian countries, something like Singapore. Now, you'll see on the slide here that there are other alleles, and it kind of makes sense. We have star 1, star 2, star 3, and then we jump to star 17. So we actually have some data for star 4, 5, 6, 7, and 8. We know that these are loss of function alleles, but we also know that the incidence rate in a typical population is way less than 1%. So we actually don't have a lot of good clinical data for these patients. And then for a star 9 all the way to star 16, these have been described in the literature, but they're incredibly rare, and we honestly don't even test for them, let alone know a lot about whether a star 9, 10, 11, 12, kind of what that does in terms of the antiplatelet effect from clopidogrel. Then finally, in terms of the star 17 gain of function allele, this is primarily seen in Caucasians and African Americans, but it's still fairly uncommon. So for Caucasians, we're looking at about 17 to 20% rate. And in African Americans, we're looking at about 15% incidence rate of this gain of function allele. So in terms of the clinical impact of a 2C19 loss of function allele, how common is this? So in a typical clinical trial, we're looking at roughly about a 30% incidence rate of a typical patient having a loss of function allele, typically a star 2, maybe a star 3, although this has huge implications in terms of where the study was done. So if the study was done in a North American cohort, or especially in a European cohort where you don't have as many Asian patients in the study, the incidence rate is going to be different. Now, among those patients with a loss of function allele, the plasma concentrations of this active compound R130964, this is the active antiplatelet chemical that clopidogrel is converted into, we see about a 30% reduction in plasma concentrations of that chemical. And because of that, the amount of antiplatelet effect that we see is reduced by about 25%. So those are all surrogate endpoints, but from a clinical standpoint, in terms of cardiovascular events, if you are a star 1 wild type allele where you don't have gain of function or loss of function, in a clinical trial called the Triton-TIMI 38 trial, those that were wild type had a cardiovascular event composite rate of about 8%, and that composite was death from cardiovascular causes, heart attack, stroke, things like that. And that was an 8% incidence rate versus patients with a loss of function allele who were given clopidogrel. Their incidence rate was quite a bit higher, 12.1% as opposed to 8%. If you look at that hazard ratio, that means that if you were to have at least one loss of function allele, your risk of having cardiovascular death, stroke, or heart attack is about 1.53 times higher if you had a loss of function allele versus if you had a wild type star 1 allele. And with that significant p-value, this is one of the reasons why the FDA has decided to actually put a boxed warning on clopidogrel related to its lack of efficacy in certain patient populations with a 2C19 loss of function allele. Now, in terms of those that have a gain of function allele, and again, this was a star 17, at least one of those, the thought is that probably these patients have more antiplatelet effect, therefore fewer cardiovascular events, which is great. However, that may or may not be offset by an increased risk of bleeding. The problem is that star 17 is rare enough and understudied enough that we don't have a clear sense of what would be a hazard ratio for these star 17 gain of function allele patients. We just know that they have a little bit more activated plavix in their body, but we don't know what is the overall clinical impact of that. So if you were to look at the CPIC guidelines, they describe 2C19 phenotypes into 4 different categories. So the first category is an ultra-rapid metabolizer. These are patients that have at least one gain of function allele, and again, gain of function was the star 17 allele. The second category is an extensive metabolizer, where this is just wild type, star 1, nothing crazy going on, a quote-unquote normal patient. The third category is an intermediate metabolizer, where they either have wild type and a loss of function allele. In this case, just for simplicity, I've listed as star 2, but this could be a star 3 or really any of the other very rare types. But typically this is going to be a star 2, maybe a star 3. The other scenario here that would put you in this category is if you have a combo loss of function, gain of function allele type. And in this case, this doesn't basically equal a normal type. So in a patient that has a loss of function and gain of function, the net result is intermediate metabolizer, slightly less active than a star 1 wild type patient. And then finally, the poor metabolizers, and these are probably the patients that need the most attention from a pharmacogenomic standpoint. This is a patient population that has 2 loss of function alleles, and the expectation for these patients is that they will not respond well to clopidogrel at all because they won't convert it very well to the active metabolite. So some key concepts here. 1, clopidogrel requires activation through 2C19. So this is really the main enzyme that we're worried about. Within that 2C19, we know that we have loss of function alleles, primarily star 2, maybe a little bit of star 3, and we also have gain of function alleles, specifically star 17 is the only one that we're aware of right now. And then finally, and really the focus of the next video, is that if we genotype certain patients, we may be able to change their clinical outcome in terms of heart attacks, strokes, and bleeding if we know what their allele type is and how well clopidogrel will be activated in the body.